Welcome to another episode of the MEGIN Spotlight series. We are delighted to welcome Dr. Abbas Babajani-Feremi and Dr. Maryam Rahman from the University of Florida Health. Dr. Rahman is Associate Professor of Neurosurgery, and Dr. Babajani-Feremi is Associate Professor of Neurology and AI and Director of the MEG Lab. This past summer, UF Health completed their 100th MEG scan, a huge milestone in the first year of the Institute's new MEG program. The TRIUX Neo sits within a 15,000 square foot neuroimaging suite on the Fixel Institute campus and integrates into the multidisciplinary epilepsy and brain tumor programs. Welcome, Dr. Babajani-Feremi and Dr. Rahman.
Thank you very much. I would appreciate the opportunity for myself and Dr. Rahman to contribute to this spotlight, and we would be happy to take question and explain our program.
Thanks for joining us. So I'll start with our first question. How has the multimodal neuroimaging suite at the Fixel Institute benefited from having a MEG?
Sure. Yeah. Thank you so much for this question. So we have been, or MEG is new at the UF. MEG has been added to our neuroimaging center that we have here. So our neuroimaging center established close to 2 years ago with the MEG that we purchased from MEGIN, in addition to 3 Tesla MRI, PET-CT, and the other facility that we have. So Nicole, I have a few slides. So I wanted to introduce our new neuroimaging center here. As you know, we get the MEGIN 4th generation MEG technology TRIUX here. So these are some pictures, our center. So this is the entrance of our new neuroimaging center. We name it DMN Neuroimaging Center, which is located at Fixel campus. So we have an MEG, we have 2 3 Tesla MRI, one dedicated to research and another one dedicated to clinical work, in addition to a PET-CT. And we also have a lot of space for clinical trial and other stuff that we have all in the same roof. And I wanted to thank all of my wonderful team of MEG Lab that helping me during the past close to 1.5 years to establish our program and getting good clinical and research work done.
So how is MEG incorporated into the operational flow of the epilepsy program? At what point might a patient receive a MEG scan, and how might this inform clinical decision-making?
Sure. So in our epilepsy program, MEG is used as part of the comprehensive pre-surgical evaluation process we have here. So patients typically undergo MEG after initial assessment, which include MRI and EMU procedure incorporating the video EEG and also the neuropsych evaluation. So we perform MEG prior to intracranial EEG in our center, or intracranial EEG, mostly SEEG. We do that. MEG before the SEEG placement. So we use MEG in patients with epilepsy mainly to localize the interictal discharges and to find the irritative zone, which is the surrogate for the seizure onset zone, and also for functional mapping for localizing the eloquent cortex, such as language, somatosensory, motor, auditory, and visual areas. So we discussed the MEG results in our weekly epilepsy management conference to finalize the surgical plans. We inform, MEG also inform us regarding the clinical decision as MEG helps placement of the intracranial electrode SEEG, as you know that, and SEEG is very precise procedure. If you miss the seizure onset zone, and then the result of SEEG may not be informative when you get the data after placement. So MEG is very important that you don't miss any hot target that you need to target it. Also, an MEG can improve outcome of the surgery by mapping the eloquent cortex and minimizing the post-operative deficit.
And so this also brings us to our next question. Can you tell us more about MEG utilization in the brain tumor treatment program at UF Health? Again, at what point might a patient receive a MEG scan, and how does this inform clinical decision-making?
Yeah, I'll take a little bit on talk on that, and I'll ask Dr. Rahman to comment more. So MEG, so we included MEG in our brain tumor treatment program at UFLs. So typically MEG is performed after initial diagnosis following a standard imaging like MRI and or CT. So patient undergo MEG before the surgery, primarily to map the critical functional area near the tumor, helping neurosurgeons making informed decision about the surgery. Specifically in brain tumor cases, MEG in combination with fMRI and electrical stimulation mapping, the modality that Dr. Rahman is using for her surgery, is used to precisely identify the location of the eloquent cortex, as I said, such as motor, sensor, and language area in relation to the boundary of the tumor. Also, MEG can assist in delineating the tumor margin, ensuring that we remove as much possible as the tumor while avoiding damage to the critical brain regions. Also, MEG can be used, and I mean, theoretically can be used to evaluate functional connectivity and plasticity in surrounding brain area, which helps understanding how the brain might adapt or compensate after the surgery. These are some of the points that I said. Dr. Rahman, you're welcome to add.
Thank you. What Abbas said is absolutely correct. And, the primary principle that guides neurosurgical care of brain tumor patients is balance of oncologic goals, which is achieving an aggressive resection of the tumor and balancing that with a functional outcome in terms of preserving neurologic function for patients. And that oncofunctional balance can only be achieved when we can have multimodal imaging and functional assessment of the patient, both pre-op and intraoperatively. And so, Dr. Babajani's program with the MEG has really revolutionized our ability to preoperatively assess the functional status of patients who have infiltrating malignant brain tumors. And so it allows us to, in addition to functional MRI and other things that we do, to really localize where their language and motor function are and other higher cognitive functions, depending on what our paradigms are that he uses to test. And so we can know where that rests within the brain in relationship to the tumor. And it's really helpful for us to know those relationships before we go into the operating room to remove these tumors. And then obviously in the operating room, we use functional mapping intraoperatively. And a lot of the times we will tailor what we're testing in the operating room based on the MEG results. And so that can inform us, okay, well, this is where, speech production was, and this is how close it is, and this is where it is in relation to tumor. And so we will really focus on that paradigm in the operating room, and that shortens how much testing a patient has to go through. While you can imagine being awake and having an awake craniotomy, we're trying to reduce, all the testing we're doing with them. We want to get through surgery efficiently for them to get them off the operating room table as soon as possible. And so MEG has been really useful in terms of being able to do that preoperatively.
That's really useful to hear. And Dr. Rahman, why are the findings and data provided to neurosurgeons so essential when dealing with brain tumor patients?
The reason it's essential is that we know that patients with infiltrating gliomas live longer if you can achieve a gross total or even a supramaximal resection. But data from our group and others have shown that if you do that in the setting of causing a new neurologic deficit in a patient in surgery, you actually completely abrogate that survival benefit. And so it is important to be able to get patients through surgery safely while preserving neurologic function, at least in the long term. In the short term, a lot of patients will have temporary neurologic deficits, just kind of peeling tumor away from particular pathways, but you don't want to cause a permanent neurologic deficit. And so MEG allows us to know what we're dealing with before we go into surgery. And sometimes the data we get shows us that achieving an aggressive resection is not feasible. And the best thing would actually be to do a biopsy and then move on to medical management. And so this type of preoperative functional imaging is critical for our decision making.
Are you each able to share an example where MEG has made a difference in the treatment planning and clinical decision making of a brain tumor case?
I don't have his imaging, but we had a patient just recently actually who had a left temporal cystic lesion. And in addition to looking like a low-grade glioma, he also had epilepsy and seizures. And so this is where MEG is really useful because in addition to having a lesion in the dominant temporal lobe, and so we need to know localization of language, having the MEG to be able to assess from a seizure focus what we're dealing with so that the goals of surgery are twofold, well, threefold. We want to get a diagnosis, we want to get a gross total resection of the lesion, but we also like to control his seizures. And so that's where MEG can be useful. And in this particular patient's case, he's been seizure-free and doing really well since his resection.
So I just want to add a couple of points here that, and I mean, Dr. Rahman beautifully, raised the point that, that during her procedure, she used, multiple modality and integrate the result. We have fMRI, we have MEG, we have DTI, and she doing the intraoperative, mapping as well. So she has all these, everything, and to use that. But compared to fMRI, which I really respect, fMRI is a very good modality. I've been using fMRI for whole my career, but there's some cases that maybe result of fMRI suboptimal for mapping the critical function of the brain, while MEG can be more useful. For example, so in some cases, fMRI maybe fail to find a reliable activation due to that case that and it need the task that fully attention from the patient, and the patient could be more claustrophobic in an MRI, or patient have some cognitive impairment. The patient cannot do the task very well in the MRI. But MEG, on the other hand, really is a non-invasive modality, very less claustrophobic, and patient can easily perform the task in MEG. And our task for the MEG is much more simple, and some of them is even passive, so patient can easily do that. So in the perspective of the case that if patient cannot perform the task very well, the fMRI, you cannot a good result in fMRI, but this will be a much less concern in MEG, and we can get better result. The other option would be in a patient in pediatric cases with brain tumor. So for those cases, and if their age is a little bit young, in MRI, there's no way they need to be under sedation. But in MEG, we can definitely do some cases without the sedation. And because, again, the MEG is much more reliable, comfortable, and less claustrophobic, and we can perform it without sedation. And our task is less demanding. Specifically, I want to talk about the sensory mapping. In fMRI, usually we have a motor mapping, very reliable motor mapping. But for sensory mapping, MEG is very accurate to finding with the median nerve stimulation. We can find very accurate sensory part of the hand. And the good thing is this test is completely passive, means that patient can close the eyes and relax, and we can get a sensory map of the brain without any interaction from the patient. So all I'm saying that fMRI is a wonderful technology, but sometimes has some limitation. MEG can be used in complement, or sometimes provide some information that fMRI cannot provide.
And from a hospital administration perspective, how has UF Health achieved their ROI from having MEG technology as a standard in the epilepsy and brain tumor programs?
Yeah, so I'm gonna a little bit elaborate on this question. So as you know, MEG is a relatively large investment with the price that have, and then the typical number of patient and cases scanned with MEG is around 100 cases per year. Comparing to thousands of the cases with like MRI with maybe a similar investment. So I think the important part of a successful ROI would be having an appropriate clinical billing, which we have a good and working with time, and I spend time to having an appropriate clinical billing that can compensate our expenses. So additionally to that, I would add that MEG has been enhancing the reputation, apart from the financial part. So MEG has been enhancing the reputation of our center and provide increased visibility nationally and internationally, and provide patient trust. And furthermore, our MEG program has contributed actually in our in the surgical outcome of our patients. Also, our MEG and our MEG has supported several research projects at UF, leading to grant funding that further expanded the program impact. And ultimately, I would say that features like the internal helium recycling, which is included in MEGIN, it save a lot of cost for us and cause that our program be most cost efficient that we can have now expanding our program. I would stop there.
And how have you scaled your MEG program so quickly within a year? Can you tell us more about how you work to generate referrals from in-state and out-of-state patients?
Sure. So I think while MEG was new to UF, it was not new to me. As a director, I was fortunate to have been in the business for a long time, and as soon as we finish our installation, because I've already been in this business for a long time, we already established the procedure for clinical and research procedures. So as soon as our installation was done, the next day we had a patient, and we continue scanning our patients after that. So that was very good, that we didn't have any time losing after installation for training, anything. Everything was ready to go after installation. And regarding the external referral in your question, I think first step for us was that to building a relationship with external referral physicians. And I actually would say that I would very blessed that I have been supported tremendously from different management in our institution. It started from our epilepsy division, all faculties, specifically Dr. Kalamangalam as our division chief was really huge support of me, Dr. Rokon, Dr. Jaffe, everybody around me, extremely supporting me that we could create this the relationship with external referral. And then because of that, we get a very good referral from external of our from outside of our center. And also, we have been hosting educational event to increase visibility, to increase visibility and providing some notice from the referral, external referral to refer to us. One of them was our UF Epilepsy Open House that we had in November 2023. I think it was very good to introducing our program to others.
Can you each share how MEG is being used in emerging translational research?
Sure. Yeah, I can elaborate a little bit, and then Dr. Rahman, you can also add it if you want to add at the end. So I think in my own research, I've been using MEG for a couple of different areas. For example, MEG, I've been using MEG in investigating neurodegenerative diseases. Specifically, I've been using MEG for Alzheimer's disease and related dementia. And specifically, I'm working to develop some biomarker based on the temporal information that we get from MEG to develop early dementia detection, and also investigating some of the condition like hallucination or cognitive fluctuation in patients with Lewy body disease, which MEG can tremendously help based on its exceptional temporal resolution. Also, MEG has been used in Parkinson's disease and other movement disorders. Specifically, we have an active project here at the Fixel campus. We integrated MEG with deep brain stimulation that we wanted to investigate what happened after deep brain stimulation in the brain, having the map of the brain using MEG while we have the deep brain stimulations in a simultaneous recording and the stimulation. So, I mean, regarding the pre-surgical mapping, brain tumor and epilepsy, we already talked about that. There are other fields that are emerging, translational fields, and I want to quickly mention about that. BCI, brain-computer interface, have been used, and MEG has been used for speech decoding. The idea is scan the brain, get the brain signal, combine it with some machine learning, deep learning, large language model, and decode the speech. So another area that I have been using is the autism spectrum disorder. So mainly to improve early diagnostic and individualized intervention strategy for children for ASD. So there's other area as well, like mental health and TBI. So basically, MEG has a growing application in all of these emerging translational research.
I don't have much to add from what Abbas just mentioned. I mean, it's quite comprehensive. I think this is the power of getting these types of data, is, the ability to generate new hypotheses and questions. And from our standpoint, it's really just a privilege to be able to work with him and his team. They're MEG experts, and they, in addition to providing excellent clinical service, have been really great collaborators from a research standpoint.
Last question. Since installing the TRIUX Neo, can you please share your experience with the internal helium recycler, also known as the IHR? Has this helped to improve operational costs and efficiency?
Absolutely. I think this is the internal helium recycler is a really one of the best feature is added to the MEGIN system. So I've been in business of MEG for a long time. Previously, I'm working with another system does not have IHR, internal helium recycling. It caused that every week or every 10 days, we bring 100 liter of the helium, fill the system, and then it's evaporated. So it added the cost and the hassle of supplying the helium without this internal helium recycling. I remember that sometimes, in the past, we had a global helium shortage, and we are really panicking that we may lose our MEG. So anyway, so right now in the MEGIN system, the IHR is included, means that we have zero helium loss. Helium is recycled during the night, stored during the day, and recycled during the night. And it caused that, first of all, we save cost, because helium will cost 50K, 100K, and we save that. And on top of that, I think another important thing is just, for mentality, we are very relaxed that we are not relying on, every 10 days, to fill our system, to find and helium, filling all that. And another aspect of that, maybe more technical, is that right now or DIVAR is almost like 60%, always in the same level of the helium, is not going up and down, which if the helium is changing up and down, it's also may change the quality of the sensor. So altogether, this IHR really is a big plus for MEGing, reducing the cost, providing more technical and advanced, and also an ease of the operation.
Well, thank you both for your time today. This has been extremely informative for our audience, and it's been great speaking with you. Thank you.
Thank you.
Thank you.